Welcome, everyone, to this session of the Virtual Sjogren Summit. I am thrilled to be joined by colleague Dr. Reddy, who is the Chief Medical Officer at Sjogren. She's going to share a little bit about her background, and then we are going to dive into some questions, talking all about Sjogren's and a little bit about what Sjogren is doing related to our condition as well.
Thank you, Dr. Wada, and thank you for having me. As Dr. Wada mentioned, I'm Prashanti Reddy. I joined Extension as a medical director a couple of years ago, and now took on the role of chief medical officer this year. I've been working in this field for 15 plus years. Initially, I started out as a hematopathologist in a private lab called Genoptics. I worked there for a decade and then moved to Kaiser Permanente. I worked there for 5 years. I was the chief of hematopathology over there.
Amazing. Well, I know one of the things that really is a frustration amongst the patient community is this diagnostic delay in Sjogren's disease. And I'd love to hear your thoughts on what's driving that diagnostic delay and how the field is working to close that gap too.
Certainly, I agree. The hard truth is that the average time to Sjogren's diagnosis is still somewhere between 3 and 5 years, and even some articles quote 7 years. And that's potentially years of damage accumulating before anyone intervenes in a targeted way. Part of the reason I believe is that our traditional markers like ANA or anti-SSA and SSB, they're useful, but they're incomplete. They miss a meaningful subset of patients, and they tell us very little about how active the disease is actually. But then what's changed is that we can now look at patterns of immune activation, not just whether a single antibody is present or absent. And that matters because earlier, more precise diagnosis is often what determines who gets monitored closely, who qualifies for an emerging therapy, who might be a candidate for a trial. And at Excision, this is exactly the problem we have focused on, building diagnostics that give clinicians a fuller picture earlier in their journey.
I think that's so huge because it's really hard in a system where patients don't have as much time with their clinician, that having some ability to, with greater precision and great sensitivity and then good sensitivity too, like being able to know who really has disease and getting them access to care. So with several therapies now approaching FDA review and hopefully approval, what does a clinician and what should a clinician know about a patient before putting them on one of these new treatments?
Great question. As these therapies get more targeted, biologics, B-cell modulators, patient selection matters more, not less. So the right drug given to the wrong patient profile is a missed opportunity for everyone. So clinicians really need to understand the disease subtype, the degree of systemic involvement, what is the current disease activity, what is the biomarker profile, not just like how severe the symptoms or how does that patient feel in that week, right? So this is the point where diagnostics stop being like a pre-referral checkbox and they become part of the treatment infrastructure itself. And for patients in or near a clinical trial, that baseline characterization is critical because it's how we measure whether a therapy is genuinely working or not. Honestly, this is an exciting inflection point. And I do feel that for the first time in Sjogren's diagnostics and therapeutics, they're evolving together. And the partnership we have built with biopharma teams running these trials are aimed at making sure that when a therapy does get approved, we actually know how to use it well.
It's huge, especially when we think about the very different mechanisms that each of these medications targets. Beyond medication, in your mind, what does thriving look like day to day for a patient with Sjogren's right now? And how should patients be tracking whether their disease is stable versus progressing?
Right. So for me, thriving in Sjogren's is not just about managing symptoms. It is about knowing whether your disease is quiet or active, because on a good day, these two can feel exactly the same. Symptom journaling has real value, but it's also subjective. Fatigue, in particular, let's take that for an example, it's very hard to interpret without context. So, what I would want every patient to know is that there are objective ways to track disease activity, and it is completely reasonable to ask your clinician about them. A few practical anchors would be: ask for a full workup at each visit, learn what your labs actually mean and which trends to watch, and understand your systemic involvement. Because for a lot of patients, Sjogren's is far more than dry eyes and dry mouth. Tools like the ones we work at Exogen are designed to give both patients and clinicians a clearer signal on disease activity over time. This would be like providing a journal for the patients to track their symptoms and bring it to their doctors.
Awesome. I think that's a good segue in thinking and talking about how the clinical picture of Sjogren's is changing and evolving from, at least what I was taught too was this is a disease of dry eyes and dry mouth, and to really conceptualizing it as a systemic disease. For many patients, they've been told for years that there wasn't much to be done. What's the message today?
Right. If you were told years ago that there wasn't much to be done, I would gently say that the picture has changed. Sjogren's was historically under researched relative to how common it is, but that shifted significantly, I think, in just the last 5 years. We now understand it as a systemic autoimmune disease with measurable, trackable biology, not just a vague cluster of symptoms. And the pipeline is real with multiple therapies in late stage trials, some built specifically around Sjogren's biology. So for long term patients, my message is simple. It is worth going back to your care team and asking, what has changed? What should we revisit, both, diagnostically and therapeutically? If there's skepticism after years of disappointment, I understand it and I respect it. But the data coming out of these trials is meaningfully different from what we've seen before.
I also tend to remind folks that the reality is that it is going to take a lot of us collectively continuing to push our care teams to read up, to get up to date on the data and to give them a little grace and patience, but also it's okay to keep poking them and encouraging them to and we've been talking a lot about that in particular with the new neurologic practice guidelines that, nope, this is a change. This is different than what we've learned. One of the other things that patients and frankly, I know personally too, really it stuck with me early on and frankly continues is that we hear that Sjogren's can increase lymphoma risk. This is like to the core of your training, right? How should clinicians frame that risk and do so in a way that doesn't create fear? And then where can diagnostics help identify those who may be at a little higher or higher risk than the general group of Sjogren's?
Right. Now, yeah, let me start by saying it makes complete sense that this word lymphoma, malignancy, cancer is frightening to hear. So the first thing to know is, yes, the risk is real, but most patients with Sjogren's will not develop lymphoma. The goal here is not fear, it's appropriate vigilance. The reason the risk exists is there is chronic B-cell activation, and most Sjogren's associated lymphomas are these B cell non-Hodgkin lymphoma. We call them MALT lymphomas, mucosa associated lymphoma in the salivary glands. So the patients who warrant closer attention tend to show specific signs like persistent salivary gland enlargement or swollen lymph nodes, certain skin findings like a rash, and in the blood work, they may have low complement or can have other markers of systemic immune activity. So, for patients listening, what I would ask is this: report any persistent gland swelling, new lumps, unexplained fevers, night sweats, weight loss, or anything real change in your like a fatigue pattern, right? Don't self diagnose. But again, don't ignore any new objective changes either. This is where comprehensive characterization genuinely helps.
Mhm.
And our role at Exogen is not to tell every patient that they are at very high risk. It is to help clinicians build an objective picture of immune activity so that right patients get the right level of monitoring at the right time. We talk about this precisely so we can catch changes early. And that's very different from saying most patients will face it.
Yeah, I think that's huge. We've
Right.
incorporated a bit of a checklist in our patient care for our clinical practice to kind of go through those high risk markers and screen for them periodically,
Mhm.
just to try to better delineate. But gosh, I know that I've talked with your team about. I'd love to have a panel that I could just order. So, um,
Right.
so, what should a patient bring to their next visit with their rheumatologist or maybe their ophthalmologist or even maybe their neurologist to have a more productive conversation, especially if they're hoping to access some of these emerging therapies or enroll in a clinical trial?
Right. A few practical things. I would say come with your history organized. Prior labs, prior diagnosis, what's been tried, what has not worked. Then ask about your full disease profile with a question like, do we know how active my disease is systemically? Not just like looking at the symptoms. And if you're seeing a generalist, it is reasonable to ask for a referral to Sjogren specialist or a center of excellence because the complexity of the disease really warrants it.
Mhm.
And know your resources, the Sjogren's Foundation, patient registries, and summits exactly like this one are part of the toolkit for them. There are also diagnostic tools now that your clinician may not be using by default. And it's completely fair to ask whether a more comprehensive workup would give you a clearer baseline. But here's the most important part. You don't have to do all at once. Pick one question to ask at your next visit. That's a start. And here at Exogen, we focus on developing patient-facing materials, creating brochures that are clear and easy for patients to understand, as well as white papers that present information in an accessible and meaningful way, along with a symptom tracker to help patients monitor and manage their condition.
I'm curious, there's, so much momentum around Sjogren's. What is giving you the most optimism about where Sjogren's care may be in the next 3 to 5 years?
What gives me the most optimism is that all of this is converging at once. Better diagnostics, a maturing therapeutic pipeline, and a far more organized patient community. That's not a coincidence, it's compounding. And the fact that biopharma is now investing in Chauvin specifically rather than treating it as a footnote in lupus trials, this signals real scientific and commercial commitment. And patients today are more informed and more organized than ever, which is genuinely changing what researchers and clinicians prioritize. And events like this one, led by people like you, Dr. Wada, who actually live this experience, are part of what's driving the field forward. For us at Exogen, the optimism comes from sitting at the intersection of all of it, helping build the diagnostic foundation that makes this new therapeutic era work. We're not just watching it happen, we are trying to build the groundwork for it.
Amazing. Thank you so much for listening to me when I share my grievances, especially our folks who are seronegative and the need for better diagnostics and for sharing your perspective and all the work that you're doing to help support our autoimmune and specifically our Sjogren's community. Thanks so much, Dr. Reddy.
Thank you.